All right, well, good morning. I'm going to talk about, as Brian said, medical psychosis, and I'm going to include delirium in this. Interestingly, although I've always thought of it as medical psychosis, it gets controversy in the literature about whether it's actually medical psychosis, but the truth is it is probably one of the more common situations where something going on in the body actually leads to changes in the brain that cause problems. So I'm going to end with delirium at the end of this. Um, Given the group that's here, you know what psychosis is, so I'm not going to go through all the symptoms and signs, obviously, but um, the idea here is that the person has signs and symptoms of psychosis, like delusions, hallucinations, the usual type of things, sometimes odd behavior and so forth. And it is determined that it's not a primary psychotic disorder. It's not schizophrenia or schizoaffective disorder. It's not major depression with psychotic features or bipolar disorder type 1 with psychosis type features. So that's the concept here. So some of this will be done often in a hospital. Lots of tests are run. I'll touch on some of those to determine, okay, it really is being caused by something that's changed in the physiology, and that is leading to the brain. And what I find interesting about this topic is that yeah, you know this, but it really wasn't until 2013 with the DSM-5 that medicine finally actually reconnected the head to the rest of the body. We've had this dichotomy, very artificial, obviously, for hundreds of years, in fact. But even in the 100 years of organized medicine, we've kept this separation, which has, of course, led to some of the stigma. And so I think ironically, if people had paid any attention to medical psychosis, they would have realized, of course, that the body was affecting the brain. We already know that the brain affects the rest of the body because it controls the endocrine system and so forth through the pituitary gland and everything else. So, for some reason or other, we missed that fact until 2013 when we finally get all the codes to be the same for psychiatry as well as the rest of the medicine. And so forth. So that really was a change. I'm not sure everybody's quite realized how different that change was in 2013 for the DSM-5. So they go through, obviously, you do a full history and physical. You're looking for what's going on. Often you need collateral informants, as we may need in other illness diagnosis as well, because the person may not be able to tell you exactly what was going on and what changed in their life. I'll give you an example of a patient of mine when I get to that type of psychosis, and that really makes a big difference. Obviously, like any other diagnosis that we do nowadays, there needs to be significant distress or functional impairment in some aspect of life. So, academic life, work life, relationship life, so forth. So we don't overcall these now, and that's been to change gradually through the DSM iterations that we try not to overlabel at this point in psychiatry or medicine for that matter. So it's, again, differential diagnosis still includes these primary psychotic disorders, the ones that you talk about a lot in this echo. So I won't belabor that. But when you get to medical things, we're talking about substances. And of course, this substance could be a person with a substance use disorder. That actually could lead to a psychotic illness. We saw a huge change in this when you all remember this, when suddenly Sudafed was put behind the counter. You had to ask the pharmacist to get your singular box of Sudafed if you had congestion. And the reason for that was because, of course, the street chemists were turning that into methamphetamine. When that occurred, the street chemists were smarter than the rest of us, and they found another way to make methamphetamine. The new methamphetamine, as it were, is way more toxic to the brain, causes psychosis much more than the original methamphetamine, and is really why you hear people complain about people showing up in the ER or in Summit County at psychiatric emergency services or detox with methamphetamine psychosis, because that was not a big common thing in the past. It really is due to this newer version of methamphetamine. And those who work in those trenches wish they would just put the Sudafed back in front of the counter because they'd rather see people on that meth and so forth. So there's real issues here. And as these substances keep coming out, there's a big discussion now about kratom. If you concentrate the main chemical in kratom, 7-OH, there's battles right now at many states are working on whether or not to make this legal or illegal. Right now, it's kind of neutral. It's a T in its common form, so it's kind of harder to make that illegal. But when you start concentrating it, which is what we tend to do in the substance use world, it gets to be more of a problem, and that can actually lead to psychosis. Now, the finding in these high concentrations. Delirium, I mentioned. I'm going to come back to that at the end because that's a little more complicated. And again, for whatever reason, the literature separates that out from these other types, even though that's probably also artificial. Homeostasis. So the brain is constantly, as is the body, trying to keep a balance. And anything we put into our bodies that then affects our brains throws off that balance. And the brain is amazing, as is the rest of our bodies, most hours and most days, and going back to this homeostasis, back to this equilibrium or balance of the many systems that are happening as we are talking right now. But when you throw that off metabolically or with medications or, as we said, substances, oxygenation can change, blood sugar levels change. That throws off homeostasis, and the brain has only a few ways to react and to demonstrate that it's in distress. One of those ways is psychosis, right? So the brain can only put out how many signs and symptoms can the brain create. It really is a limited list. If you were to make a list, it's not an enormous list, and that list includes, of course, hallucinations and delusions, because the brain has to, and I think we forget this sometimes, it must interpret the chemical and electrical signals that it believes it's receiving from the five senses. But if those signals are occurring inside the brain can't sense itself. So when it doesn't sense itself, it has to make sense of these signals. And it only has a few ways to make sense of them. So it's going to think it hears a voice. It's going to think it's seeing something that others may not be seeing. It's going to possibly head toward delusional thoughts. What's going on? I'm perceiving things. I need my brain. Your brain cannot help it is the point, right? So then medical psychosis falls right into this because the brain also doesn't know that the body's in distress and leading to the brain having this distress. So that's where the physical medical conditions can come in. Some of the connective tissue disorders, multiple sclerosis, and others can, of course, affect the brain, and those also then can lead to a psychosis. So what is different about medical psychosis from what often is talked about in psychiatry in terms of psychosis, where we're talking schizophrenia and so forth, is one of them is it's sudden. It often can be in a matter of hours, the person can go into this psychotic state. Maybe there's a bit of a prodrome, but not in the way we think of schizophrenia, not a 6-month prodrome. We're talking hours or days, for example, and the person ends up with the psychotic signs that we can observe or symptoms that they can tell us about. And again, delusions can occur there. They're generally non-bizarre, so that may be a differentiator from schizophrenia, although people with true delusional disorder often have non-bizarre delusions, although they tend to be longer standing, so there should be a way to differentiate that from a sudden onset delusional thoughts. Hallucinations, this is different because in schizophrenia, we tend to think of auditory hallucinations as the most common. In a medical psychosis, visual hallucinations, even tactile or olfactory smell hallucinations are more common. So that may be a differentiator as to saying, okay, something else is going on. It's happened fast, and now they're having visual hallucinations right away. Now, again, that could be methamphetamine, right? It could be withdrawal from substances can do some of this. Tactile can be withdrawal from stimulants. But in general, this is a different character than you see in schizophrenia. The fluctuating level of consciousness often is due to this change in metabolic stuff that's going on in your body, which we'll get to a little more in a few moments here. And that often is, that actually is a hallmark of a delirium, is this waxing and waning, more awake, less awake state. And in delirium, which I'll say again, often their sleep-wake cycle is reversed. And I can think of patients I saw even in my training in the hospital setting where that was clearly the case. And then because we're affecting the brain, the person may have either cognitive impairment and or personality changes. which they normally wouldn't have. So the person now is doing things that they wouldn't do. If they're in a hospital setting, that might mean making crass remarks that are out of character of the person, or they may try to pinch the behind of the nurse who's caring for them, things that would just completely out of character for them. There's this personality change, and there's these filters that get dropped, so they're somewhat disinhibited as well. Um, so uh, obviously, if we damage the brain, this could lead to it, right? So certainly people have personality changes, and less commonly, but it can happen, psychosis from traumatic brain injury. So that's the most direct type of brain damage. But as I mentioned, some of the other illnesses, connective tissue disorders in particular, can also ultimately have damage to the brain, either the white matter or sometimes even the gray matter of the brain. And that will then lead to the brain. The signals are disrupted, and the brain again has to interpret those because the brain doesn't understand that it itself is ill. The brain cannot feel itself. And I'll do this quickly because I think this is helpful. If I ask all of you right now to think about your left foot, you can do that. You weren't. Now you can. If I say to you, now tell me about your right temporal lobe, if anyone's able to do that, please call me out because I'd love to. You can't. Your brain just doesn't have sensory of itself. Interestingly, and now there are nerves around the outside of the brain, so brain surgery would be painful if they didn't numb it and all that stuff. But there's not inside the brain itself, so it cannot sense itself. Right? We think of our consciousness, our mind, as opposed to our body, but that's different. We're still not sensing necessarily correctly what's going on inside the actual skull cavity, and so that's a problem potentially for us. And of course, it's partly why that person, like somebody with schizophrenia, may not have insight into the fact that they are having this metabolic or medical psychosis. So they also aren't aware of this. And again, at some points it can become extreme, and then they obviously in hospitalization and other items are needed there. The hormonal and metabolic abnormalities, absolutely. I think we probably don't do enough justice in the endocrinology side of things often, and in all of medicine. I don't think that gets looked at. I think the advent now of the GLP-1s, like tirzepatide, for example, which comes as Mounjaro and Zepbound brand name, we now know it does a lot of stuff, right? And so those of us who hadn't spent much energy thinking about endocrinology for some years, myself included, it's a huge reminder that and these are tiny amounts of substance that get into your bloodstream and signal all sorts of stuff around the body. So those changes in hormones can make a huge difference. We think of hyperthyroidism, right? So hypo tends to be related somewhat and sometimes directly to depression. Hyper may appear as a hypomania or even a mania. And I saw one extreme case years ago in the hospital. And we can see those hormonal changes. Those will be extremes, but that can happen. And then metabolic abnormalities. So something is going on. This can be as simple as somebody who has a low red blood cell count, so some version of anemia. And what does that mean? Well, that means they're not carrying as much oxygen. So they may be breathing fine and their heart may be pumping fine, but they're not carrying enough oxygen. So, they put the little pulse ox on our fingers when you go into an ER or whatever. They're trying to see what's your oxygenation level. Well, if that starts to drop, even the low 90s, but certainly if you get below 90, we start to see the brain's not doing so well. The brain needs two things generally all the time: oxygen and glucose to burn for function. So if we affect either of those in one direction or the other, it's a problem. So I'll go to glucose next. If our blood sugar is way too high or way too low, and I just saw an article about the high percentage of Americans that either have pre-diabetes or actual diabetes. So this is something we will see this. Their sugar gets thrown off. And if it's thrown off suddenly, that is more likely to lead to this mental status change, which could be a psychosis. And now many people with a pre-diabetes or diabetes, it's gradual. And so guess what? Our brains are really adaptive like the rest of our bodies. So we adapt to that. And you may not see that. Just no different than someone with an alcohol use disorder who we see them, they look perfectly fine at a 380 level, But if I had anywhere even close to that, because I rarely drink, I'd be dead probably at a 380 blood level, right? So that person has tolerated that and adapted. The same thing happens with blood sugar. Our brains, we may discover this person's blood sugar is 35 before they pass out. Most of us would probably pass out at 50, which is very low. So it's a very low. And paramedics in our CIT class often bring this up when we discuss this. And then immune-mediated brain inflammation. So we could probably do a whole series on inflammation because that's, of course, the big ogre now in our bodies. And so when you've got inflammation, in this case, because there's usually it's autoimmune, the antibodies are attacking something that can actually happen in the brain. The brain, of course, has mechanisms to clear itself of infection and so forth. A lot of what happens overnight, it's clearing out a lot of these metabolic metabolites so that we can continue to function the next day. And if that doesn't happen and we end up with inflammation in the brain, same issues, it throws off the signaling, and that can then, of course, present with a mental status change. And today we're specifically talking about psychosis. So here's a big list. I'm not going to go through all these, obviously, but it gives you a general list of the types of things. So like here's the autoimmune encephalitis, brain swelling, inflammation of the brain is the fancy word. Every time you see itis, you probably know that, but that's inflammation. The infectious diseases, for a long time in this country and many countries, something like 1/4 of all of the state psychiatric hospital beds, and that's back when we had 500,000 people in them, were due to neurosyphilis. So syphilis starts off when people get it, and unfortunately it's on the rise right now as an STI. It used to be called STDs. Now we say sexually transmitted infections, but instead of disease. But it starts off with a skin lesion, but then it can go dormant. It can then come out as a rash, and then it can go dormant for years or decades. And meanwhile, it is destroying their nervous system. And these individuals ended up, and we didn't know this back in the day, so these individuals did not get treated, which, by the way, then and now is still penicillin, which is amazing. It has not become resistant after hundreds of years. And the net result was these people end up in the psych hospital. And this was one of the two great imitators in terms of the number of psychotic or other mental health symptoms the person might have. Neurosyphilis is right there at the top of that list. HIV is another one that can present with a lot of different types of psychiatric symptoms. Again, it gets everywhere in the body. It's messing with our immune system, basically wiping it out at its full when it really moves into AIDS. And of course, our medications now are way better than they used to be at dealing with that. Even single pills with multiple drugs in them now to target HIV. So that's been a success for humankind that we've been able to do that. Another big imitator in terms of psychiatric symptoms is B12 deficiency. So people with very low B12 can end up with lots of different symptoms. Psychosis is rare, but it happens, as I was reading about that, just to try to get a sense. But that's another big imitator that can cause a lot of haywire in our nervous system. And therefore, again, the brain can only present with a certain level of signs and symptoms. They may also manifest from that. Renal failure is a big one. So the kidneys, of course, are also functioning sort of like the brain does after hours when we're asleep. The glia cells and others are trying to get rid of all of those metabolites that need to be out. Our kidneys do a lot of that for our bodies. And so individuals who end up with renal failure, if they don't have dialysis, all of those chemicals, those metabolites from all the stuff that happens in our body, even as we're speaking, they accumulate. And they just accumulate, and eventually they are going to also affect the brain because they're in the very same blood that's going into the brain. The liver, if it has a problem, they end up with basically way too much ammonia levels. And that ammonia is something that then can cause this encephalopathy. That used to be something we would test for regularly when I was in hospital-based psychiatry. And more of the general hospital-based psychiatry than the state hospital. But in general, these individuals would have signs and symptoms. They can get like a flapping of their hands if you have them hold their hands up. There's ways to test for this. Again, to rule out, is it primary psychosis or is it something else going on? I've covered most of these. Again, I already mentioned anything that hurts the brain, brain tumor. Epilepsy is a big one. There's actually a lot of discussion right now about epilepsy and the psychosis that can come from epilepsy. And interestingly, they make use, Dan Brown, if you're a fan of his novels, Da Vinci Code and the like, the newest one, The Secret of Secrets, actually has epilepsy very much centered in some of what goes on in the Secret of Secrets book. So if you're interested in a good read, or in my case, a good listen on Audible, and of course the libraries now do it for free, they're worth it. Parkinson's is another disease that we know, and of course we hear about it through certain movie stars that are very big in this sector in terms of talking about it. But it definitely can move people into psychosis, definitely some cognitive issues. Initially, it starts out more as movement disorders from what's going on from the Parkinson's and the brain being affected and so forth. So, and then of course, stroke directly damages the brain. So there's no surprise there. We know that left-sided stroke, historically, the research says is more associated with a major depressive episode. So it's possible for the left-sided stroke later on, as that's healing, that the person ends up with a major depressive episode. But stroke can also damage parts of the brain that lead to, again, misinterpretation of reality, because the signals are not exactly going on correctly in the brain, and that can be interpreted in psychotic ways. Anybody know what the most common, it's prescribed, but it's very commonly prescribed medication is that may lead to psychosis in any one of us, actually, healthy or not healthy? Anybody ever seen this happen? So I'll tell you by way of quick anecdote. So I had a private practice for a decade seeing workers' comp patients, because I do psychiatry and the law, so they all have attorneys and everything tied to it. So I found that side of it interesting, although frustrating. And the net result was that I had a woman who was doing very well. She was a teacher. She had been attacked in school, actually, and had a lot of reactions to that, and came to me. And in general, unfortunately, a lot of the people who end up with workers' comp never go back to work because of the way, partly the illnesses they get, and partly the system that's built to help them. But she ended up, we worked with her for years. I saw her for several years. She ended up going back to work, and she was doing great. And she, at that point, we had her down to one mild antidepressant, and nothing major, and she was doing fine. Actually heading toward retirement even at that point. She was doing so well. And I got the strangest voicemail from her that I'd ever gotten. And thankfully, I called her right back within like an hour. She was still hiding in the break room for the nurses. Sorry, thinking hospitals. The break room for the teachers, because she was a teacher. So she's hiding in the break room, and she was talking fast. And so I asked her some questions. And when a layperson is out of sorts, they have one fear, and one fear only. And sometimes it doesn't even matter if they have a lot of other education. The fear is they're having a nervous breakdown, right? That phrase has not gone away. So that was her fear as we talked. And so I asked her some questions. And one of the questions I asked her was, well, before this, and she was able to have a conversation, albeit a little fragmented. Were you having any other illnesses? And initially she said no. And I said, well, anything that affected your breathing, a bad cold? And then, of course, she did ultimately reveal she had bronchitis. And guess what they gave her? Because this is what it's commonly given: prednisone. The prednisone taper pack, right? So you get a whole bunch of pills on day one, and then you take one less on day two, and one less than that on day three, and you have this taper called a steroid taper. That is actually a very common cause of psychosis. And it is, albeit higher doses are more likely to cause it, it's not only dose dependent. That is, there's some people with low doses, especially if they had a previous episode, that can end up with psychosis. So I put that out there because I've experienced, that was not the only patient I've seen that with. Again, not by my hand. I'm not usually the one prescribing the prednisone pack, but it's interesting. And I think it's worth noting. So that one throws people off, and that can be like by day three of their pack. And so of course, in her case, I said, here's what you're going to do. Don't take another dose today. Call your doctor right now who prescribed it. Explain what happened and why you can't continue this, and see what else they can give you to deal with whatever residual bronchitis stuff you've got. And actually, it turned out that had already resolved pretty well. She probably never needed the prednisone, but I'm sure the day she was seen by the prescriber, it looked like she needed it, right? So she actually was on the mend, and nobody could tell that looking at her. That so anyway, that's just one example. That is a very common example. I have a family member who took prednisone as well, and in this case, I think was probably, I have to remember now, probably like 15 years old. It was very clear, not psychosis, but definitely threw off mental status for a few days. It was like, okay, let's watch this carefully, and did, and everything was fine. The family was all like, what's going on? But it was definitely the prednisone packet. Again, also actually for a bronchitis type situation. Sleep deprivation. We don't think about this very much, but yet we all complain when we don't sleep well enough because that's the human condition. And sleep deprivation, definitively, again, for the same reasons I started to say before, your brain's not clearing out all of the metabolites from all that stuff that's going on in the brain and the body. And the net result is anybody with sleep deprivation can end up being psychotic. Now, they do train our military very well on how to deal with this, so they can actually go more days without sleep than most of us. But other than that, even they eventually can become psychotic, and that takes a lot to deal with because, of course, one of the things is we have to force them to sleep, usually with medication and so forth, to get the person back to a more normal mental state. And that can actually take a number of days for sleep deprivation if they've really been forced for whatever reason to be in a situation where they could not sleep for days on end. Oxygen, I mentioned by way of anemia, but there may be other mechanisms, but that's the most common one, an extreme anemia. And obviously, again, food and fluids, right? We have to have enough fluid for all the things that water does for us. A lot of our bodies are, and percentage-wise, are water. Food, of course, as I said, the brain only ultimately burns glucose. So if for some reason we're not getting enough nutrition for the body to make glucose for the brain to burn, it's going to affect the brain's ability to metabolize and have energy, et cetera, to do all the great things it needs to do. Let me watch my clock here a bit. So let me jump to delirium, the last big topic here. We've covered a lot already. And I did borrow these slides. You'll see at the bottom I gave them credit from the Academy of Consultation Liaison Psychiatry. So consult liaison psychiatrists are the ones who work at the interface of physical medicine and psychiatry. They go around the hospital and do consults by request from all the other specialties. The other physicians will request this, again, to figure out the differential diagnosis. What is going on with my patient, and what advice do you have? They generally give advice. They don't write orders. There are some hospitals where they will let them, but by and large, they do that. SUMA, for example, I know does that very well. Dr. Todd Ivan is excellent as a consult liaison psychiatrist. So he has to keep up on a lot more physical medicine than many other psychiatrists who might not be in that situation. So he's always going in, often with a resident, trying to figure out what's going on with this particular person. So in a delirium state, the person has officially, because these are diagnostic criteria, has a disturbance in their ability to attend to the current situation, their awareness, so they may not know the date. They might not even know the season. So that gets into clear mental status issues, right? If somebody can't do that, and that alone doesn't mean it's delirium, but because other illnesses can do that. But that's a big one. Rapid onset, as I mentioned, fluctuating mental state. So they may lose that sleep cycle. They may be relatively awake and then relatively suddenly asleep, or at least obtunded, and not able to have a conversation, and it fluctuates like that. They tend to have some cognitive issues with that, which again is probably unclear why. I mean, if you're sort of half asleep, half awake, you're probably not all that cognitively intact anyway. So that one, I've seen a lot of research trying to figure this out. Is it a separate sign, or is it something else? They do look to rule out other neurocognitive disorders, but again, in general, this is such rapid onset, they're going to treat as if it's delirium until proven otherwise. So clearly it's coming from a general medical condition. Lots of etiologies. Any of the things I listed already before actually could lead to delirium. Does anybody know the most common cause of what could present as a delirium in an older adult? Women more than men?
UTI?
You got it. Perfect. Thank you, Dr. Rupp. It's a right, urinary tract infection. It gets missed. We still see this in our system, even a nursing home. Suddenly, the person's mother is just not. They're talking strangely. They're behaving strangely. Their sleep wake cycle may be a mess, and that actually has a bad prognosis for individuals, unless because it's an infection, unless they get it solved and sent to another place, usually another hospital. There's one in actually in Hudson now for some year, I guess for probably a decade now, called Assurance Health. It's a very small, I think 23 beds. They specifically treat people from nursing homes that have illnesses that need more work, usually in the psychiatric arena. They will get people, probably didn't need to get them. They come in, and it turns out it's UTI. They could have tested that and of course the treatment is simple. It's antibiotics. So the person can look floridly psychotic or floridly delirious for a day or two or three if they don't catch it fast enough. And they give them antibiotics, and it's like a miracle cure. And families, of course, rejoice because they thought they were losing their loved one to whatever was going on with their brains. So UTI is another one of these that's very common and more common than it should be. By the way, in women, of course, younger women, it's easier for them to get UTIs. They have a shorter urethra than men do. But as men get older, they also can develop UTIs more likely than when they're younger. Issues with prostate and so forth that I guess the research says all of us get if we're a male, if we live long enough. Just a matter of what your year is of age before you get to something with prostate. And once that occurs, it's more likely to get some bacteria up in there that can lead to the urinary tract infection. Um, so here's the classification as they look through it, trying to figure this out. What type of delirium is it? And for time's sake, I won't review them all, but you can see them here. Lots of issues here, but they do try to figure out what the cause is. Sometimes knowing the cause helps the treatment, although they may already have to treat with medications. Haldol is a very common one. High potency, low dose antipsychotic is one that actually gets used still. Starting, back in 1952 or so, it's continued to be a very good drug medication for this particular type of illness. Acute confusion for sure. This also sometimes gets called ICU psychosis, right? Because it's very commonly, this is the person in the ICU has a lot of metabolic stuff going on usually. Nobody's lightly put into an ICU. So whether it was a drug overdose, maybe an intentional drug overdose, they obviously took so much, they're throwing off their body and their brain, or it was some other illness that put them in the ICU, they're a mess, technically speaking. So that often is a place where they end up with this type of delirium. Interestingly, I like this one, reversible dementia. I think this is actually important to mention because somebody has relatively rapid onset dementia. Well, dementia so far we're not very good at treating, although there's a lot of research trying to improve this. And there's some medications that will slow it down a bit here and there, but usually only by about 6 months so far. But if you can find something else that's presenting as dementia, it's almost certainly more treatable than dementia. So delirium is one of those situations. And the other one, of course, is pseudodementia, which is major depressive disorder. So there are two things that they're often gone after that actually are reversible dementia. As far as delirium goes, that's one of those reversible dementias that you can see here. Increased mortality. So the reason I also end with this one is that of these lists of medical psychosis, the highest mortality rate is delirium. It is not a good sign that a person in the hospital, especially an older adult, ends up with delirium. It probably means they're at some level they're more predisposed to it. And again, older adults are more predisposed than younger individuals to this. And that may mean there's issues with the brain already that got disclosed by whatever metabolic disturbance led them down this path of delirium. So very is a problem. And then, of course, with increased morbidity. So this is not a simple illness. And obviously the goal would be to prevent this when possible, because it does lead to the person. You can see their mortality, big gap here in terms of with delirium. This is the top line, and without delirium, the bottom line here. I already mentioned older adults. If they've already had vascular changes and so forth, there's big issues there. Any central nervous system disorder, no surprise, more likely to lead to a delirium. Multiple medications. And if we start a bunch of new meds, again, what did I mention? I'll bring us full circle here. Homeostasis, right? So start taking these medications. They go some through the liver, some not. They get turned into the active medication. They go into your bloodstream. They go therefore into your brain. And if you hit your brain with a whole bunch of new stuff, it's trying to again get back to homeostasis, and that may not happen as rapidly, especially if the person's older or very, very young, and that can lead to this delirium. Burns. Oh my gosh, horrible, horrible situation with burns. Of course, there's all the fluid loss. You are literally losing. Number one, you're damaging the biggest organ in the body, and number two, it's a barrier. And so now you're opening up the body to potential infection and other types of things. And the metabolic changes that occur as your body attempts to deal with the burn can then lead to this delirium as well. Some of these I've already mentioned, so I won't belabor it. Some clinical features, real quickly. I got 2 quick slides on this. This diffuse cognitive impairment. As I mentioned, attention is part of this, right? They really can't focus and pay attention. Again, that fluctuates, though. There may be periods of the day where they're a little better than other periods of the day. The memory, for sure, is thrown off. Some individuals will have very, very vivid dream-type states during this, and literally when they're better, they will still remember those dream states as though they were reality. My own grandfather, my father's father, had this happen, and in his case, it was because they were giving him some reason at the time, years ago now, a lot of years ago, but fairly potent opiates to deal with him. He unfortunately had ended up having a leg amputation, partial leg amputation, I think related to a football. He was a college football player. I did not get his big genes, but and so he ended up having this horrible situation. And during the recovery of this, once he was better, he would start telling us about some things that clearly never happened, and they were clearly in his delirious state, things that his brain latched onto and held onto as a true memory. Very, very interesting, fascinating, especially for someone like me who's interested in the brain. So very, very fascinating. Disorientation. So I mentioned this time and place issue. They don't know where they're at. They don't know what day of the week it is, let alone what season it is, maybe. They tend to know who people are. So that's why I say rarely to person. They tend to know who people are. And of course, any of the cognitive stuff, the executive dysfunction occurs here. The thought disturbances, they can have disorganized thoughts, so they aren't able to really give us a good answer to questions necessarily. Might get the disorder, so similar to what you might see in the schizophrenia situation. Language. These are interesting things because, again, the brain is just not working right. So they can't find their words. The drawing issues are messed up. So the dysgraphia, they can't speak right. That's the dysarthria and so forth. The perceptual disturbances we've already talked about, that's kind of the point of why we're talking about that today in this particular echo. More things that you would expect, as I've already reviewed, I think most of these. I didn't mention their affect, so they can have a lot of affective lability. I actually, as I say that, I can picture a patient I saw who would lay there placidly and then suddenly just start screaming at people. And even one time when nobody was in the room yet, we were about to walk in the room. So they had this back and forth, and then this similar, that same patient actually, then that evening was just laughing uncontrollably. So this affective lability, their brain again trying to come back into some homeostasis, wasn't able until we were able to deal with the causes for that. So here's real quickly, the differential diagnosis of delirium. If you want to look at this versus dementia, right? Delirium, again, I've said fast, dementia, slow and insidious. Depression, variable in this case. After the fact, though, actually can occur. You see the fluctuating course here, whereas the other two are generally stable. Again, length of time, hours to weeks. If they go on with more than weeks of delirium, they probably don't live, unfortunately. So that's really a sad situation, separate from the actual delirium itself. You see here, consciousness, not such an issue. They're awake and alert. They just may not have good memory and stuff with dementia. Depression, again, also tend to be clear, but may have that overlaying dark cloud with their how they demonstrate all that. So I won't go through all this because you can read it yourself for time's sake, but that gives you a general sense that there really are some big differentiators between these three things. This shows you some of the I put a few things at the end here. Some of you learn better visually. So here's a visual diagram you can look at to walk through how these things might. So hypoxemia, which is low oxygen, or metabolic changes, derangement. So this is actually a slide that came out of Britain. I thought that was interesting. Derangement, interesting word, but we understand it. Systemic inflammation, again, the horrible inflammation, how these things can lead down here to a delirium. So pretty good slide, very covers it pretty well. Etiologies we've talked about already, so just put that on there so you've got that. Same etiologies that we saw for a lot of the other metabolic psychosis type situations. And then, of course, I did not mention as much infection. I mentioned HIV earlier, and UTI, that is here. But some of these other ones, sepsis for sure, that means you've got a widespread infection through your bloodstream. That, unfortunately, can be deadly in and of itself. And in the course of that, you may discover the sepsis because of the delirium. That I actually can recall seeing that through an attending. I was a resident at the time. My first year of residency in psychiatry, you do a lot of physical medical work as well. So pneumonia, sadly, too common, and they do have excellent vaccines now for that, which is partly to prevent this from occurring, so you don't end up with that. I think I've covered most of these. So here's an interesting way, and just an acronym, a mnemonic, right? So WIMPs, I'm not sure it's a great word to use because nobody calls anybody with delirium a WIMP, but it is a good way to remember some of these various causes for a delirium, especially the ones that might actually lead to the person's death. Just to review what you've seen, I'm just kind of watching the clock. I know you said you didn't have a presentation, so going a little longer than usual. And assessment, I think I actually had that on a different slide, kind of what do you go through at the very beginning. Treating the underlying condition, once you figure out what that is. Antipsychotics, again, tends to be Haldol, but they may give some of the medications that can also work for dementia, or they may give some benzodiazepines to calm the person down if their mood lability is too extreme, or they might hurt themselves or jump out of bed. These are the individuals who may need the posy vest, because they're not aware and they suddenly just want to jump out of bed, and they will injure themselves by doing that. And of course, this you can tell, but it's a team approach. This takes a lot of individuals to work on this situation for those people. Early recognition, better outcomes, because again, this can be a deadly outcome with delirium. That is my contact information, and I will take questions, or if someone has a short case, they can do that. Thank you.
Thank you very much, Doug. We appreciate your very informative presentation. We'll open it up to questions. I don't think we really have much time for a case, but